The other thing is, improving physical fitness and progressive loading. And who's in charge of that? That's what at least what we're potentially moving towards with this human performance model is letting the strength coaches actually be the subject matter experts and be able to actually control at least the physical training element. They were huge, absolutely crucial in regards to at least my experience in trying to mitigate some of the problems that we were seeing. And generally, folks that actually worked with the strength coaches and follow their program we saw less injuries from them than we did from those that didn't.
Hey guys, welcome back to another week with Drew and Alex. Uh, and before we kick things off, Alex had something exciting happen at work.
Exciting's a word. I don't know if it was good or bad. It was really hard to tell. Some some followers of this podcast may have gotten to know me or first interacted with me when I was at the Army Physical Fitness School. And some of those folks are probably now master fitness trainers and stuff, which means they likely are on the Army Master Fitness Trainer Facebook page.
There's a
And
Facebook page for all the master fitness trainers.
there is not everybody's on it, and some people are on it that shouldn't be on it, and like various things.
Mm.
But it is a place theoretically for graduates of the course to like discuss issues, share knowledge, whatever, stay up to date on the latest, things like that. And I think technically I might still be a moderator. I'm not really active in that capacity anymore since I left the school. But for a while there, I did some moderating of the page. And Drew, you've gotten to know me a little bit over the last few years. I was pretty snarky on that page. Um,
No.
if people say dumb stuff, it's really hard for me to just let it go. And so sometimes I let people know how dumb the stuff they said was. And I always kind of imagined that being off in like army land and Facebook land, and it would like never follow me if I left those places. And then at work the other day, a guy who used to be in the army, who's not anymore, recognized me, realized who I was, and started talking to me about that Facebook page.
Did you call him out?
No, he called me out basically.
No, no. Did you
But
had you called him out on the Facebook page?
no, I had not. Well, I assume I hadn't called him out because he actually appreciated the way I behaved on the page. He thought it was
Oh.
necessary and stuff. So it didn't end up being real bad or anything. But it turns out being a big old troll on the internet is not always in the past, especially if you do it under your real name and super publicly all the time in a small network.
I mean, I feel like every famous person slash politician ever could have told you that.
I'll tell you the most egregious one because I
That
thought it
you
was hilarious.
that
This
you
wasn't even
wrote?
my behavior. No, 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 no.
Oh.
The most egregious one that I was like the snarkiest on, a lieutenant asked if the weight of the bar counts in the deadlift. Uh, and I told him I was going to go find out if there was a way for me to rescind the skill identifier that he'd been given for the course.
Wait, just in general or on the ACFT?
I assume he was talking about the ACFT, but like the whole post was like, does the weight of the bar count on the deadlift?
Yes.
Yes. If anybody's listening is confused,
Well, I mean,
yes.
well, if he's talking about just the ACFT, I could see a case to be made because you don't include the weight of the sled on the sled drag carry weight, do you?
But the sled weighs like a pound.
Well, first of all, the sled weighs more than a pound, but I can see maybe you should apologize to him.
I'm not apologizing to him. The most
Because
outrageous one and the one that encouraged me to begin my snarky internet adventures. This might have been like the emergence of like the version of me that runs Mops and Mo's, who's kind of an asshole. Some NCO popped in and said, "Hey, I've got a guy. He just arrived to this course. He's like 3 or 4% over on body fat, but the course policy says he can retest in 2 weeks and potentially still stay in the course. What should I do to help him lose 3% body fat in a week or two?" And he got tons and tons of comments of like, "That's not your job. Don't do that. It's unhealthy. Whatever, whatever, whatever." And he ignored all of those, like all the comments being like, "That's not how this works. Like, we want sustainable weight loss, healthy weight loss, whatever, whatever." And then he got one comment that was like, "Check it out, bro. I got you. Lettuce only diet. He's gonna fast for like 3 days at a time. He's gonna do saunas and treadmills and sauna suits, and he's gonna absolutely crush it. He's just gonna destroy his health over the course of 2 weeks." He's going to lose that 3% and he's going to be able to stay in ALC or whatever the course was. And he responded to that question like, thank you. This is exactly what I was looking for.
Lettuce only diet.
It was unhinged stuff, man. It was not like,
Well, hey, speaking of people who don't know what they're doing, I think it's pretty safe to say you and I are not injury prevention professionals.
that's true.
We have since the dawning of mops and mows, and especially since the dawning of long and strong, and introducing some training into our stable of offerings. We have gotten a fair few questions on injury prevention, how to work around injuries, how to come back from injuries. And since that is neither of our specialties, we decided to bring in some help. And we brought in none other than John Romanello. Who's John?
Well, I'm gonna read a bio of John. It's gonna be real vague and it's gonna stay vague. So here we go. John Romanello is a physical therapist by trade. He has spent the entirety of his career working as an embedded human performance physical therapist within special operations and conventional military units. He has vast experience in assessing and treating sports-based injuries with a focus on return to military demands. And you might be like, hey, what does he do? Where does he work? What unit is he in? And we're going to say, no, can't talk about it.
It's a secret. But I've worked with John in the past. Super smart dude. Probably listening to this episode. Hello, John.
Hey, John.
You'll hear a little bit of a mention about this in the episode itself, but if you've not been following the Instagram or the blog or really anything, we have, since bringing John on board, we have launched a handful of injury prevention programs on the website. So we have sort of partial template offerings. If you've already got a program you're doing and you just want a couple of days a week that will focus on things like ankle rehabilitation, shoulder, knee, low back. And then we also have more comprehensive injury specific programming spanning multiple days a week, multiple weeks to really, I mean, number one, kind of build you as an athlete, but then with a slight bias toward whatever that area of injury might be. So we'll get into that in some detail in the episode, but really the point of bringing John on board today was to give his and by extension our kind of perspective on the whole injury prevention conversation.
And a second ago, I was being vague because I had to be vague, but now Drew's being vague for no reason. So I'm going to be really direct and say there are a few things for you guys to go look at when you listen or after you listen to this episode if you want to go deeper on some of this stuff. John wrote a great blog post on our overall philosophy on injury prevention. If you don't have any specific problem areas or anything like that, you just want to make sure you're like robust and minimize your injury risk, that blog post is great for you. It'll talk about foundational principles. A lot of people do get confused. Um, they think that they have to like predict what's going to get injured to do injury prevention, and prediction stuff is hard. We've talked about that before. We're not going down that rabbit hole because prediction is an entirely different situation than prevention. But the best predictor of injury is previous injury, and a huge portion of prevention is the response immediately after the injury, trying to achieve full recovery so you don't have this lingering problem, or making sure something that's a minor injury now doesn't become a major injury later. Right. So that's what all this is. If you're the kind of person who has like a nagging shoulder issue, you like roll your ankles frequently, like whatever the thing is that bothers you, you're not worried about it enough to get a ton of serious medical treatment, but it is something that you can tell is limiting your performance. This is exactly what you need. There are two categories of product that Drew mentioned. If you go on the website, you will find either the blueprints or the master plans. The blueprints are intended to complement whatever program you are already doing, but add a little bit of focus on your problem area. And the master plans are designed to be complete programs that will ramp you back into full performance in that particular area.
And I guess the other thing that we've started to talk about doing in the future is we've done FAQ episodes in the past. We've written things on the blog, sort of targeting specific questions that might come up. Most of that has centered around the performance side of things. But now with John on board, we can obviously introduce more of an injury prevention slant to some of that stuff. So if you guys out there listening do have questions about coming back from injury and or, well, I might be speaking for John here, but like we may be able to get into the weeds insofar as like specific issues relating to your particular case, just fire those questions our way, and we'll see what we can do with them. We'll try and share some good information about injury prevention. So,
And real quickly, if you are a Long and Strong member, you do get a discount on this. Check out the chat on the team program over there to find that. And whether you use that or not, if you get one of these programs, you get lifetime access to it. So if you're worried about this not being a one-time thing, don't worry, you'll be able to come back to it whenever you want.
enjoy.
I think where this all comes from is the conversation, like the injury prevention term is thrown around a lot. There's other tangential terms, injury control, injury risk reduction. You'll see a lot of like internet semantics debates about like injury prevention isn't real because you can't prevent every injury. I think like, do we start with like defining terms and explain what we're talking about? Is that where we start?
Let's do
Yeah,
it.
I think that's good.
All right. You wanna kick us off with a workable definition here?
Yeah, sure. So obviously like injury prevention is a huge buzzword, gets people going, it riles up emotions. Whether or not you get caught up into the semantics argument, really prevention in a lot of medicine is used interchangeably with risk reduction and mitigation. Prevention is just such a strong word that really gets people fired up. So for example, World Health Organization splits up prevention into three different types. So I'll it's primary, secondary, and tertiary. And in regards to injuries, it's something like this. So primary is reducing the likelihood of a development of a disease. So that is, for example, implementing the FIFA 11 plus program in soccer to help prevent ACL tears, right? Preventing the injury from ever occurring. Secondary prevention, a lot of what I do as a PT focuses on minimizing the progress of disease at an early stage. So that could be like bracing an ankle who from an ankle that previously sustained an injury, especially in like court sports or something like that, where they're going to be going up and down on the court and jumping down, potentially posing a risk to re-injury. And lastly, tertiary, this is like halting the progression of damage already done. This is chronic injury management. So basically, long answer, a lot of the stuff that we use in medicine in regards to prevention, a good majority of that actually is not focused solely on preventing the disease from the start. It can actually be from, preventing the progression of it.
And to underline that, I think some of the most common things I see in the place where like embedded human performance seems to have like a huge potential for positive impact is identifying things early when people know there's some kind of issue going on, but they don't know if it's bad enough to go through the process of getting a referral to a specialty provider and like getting the appointment that takes a few weeks and all these kinds of things that prevent them from being seen. Because I'm sure you've seen more of this than I have, but like classic example, I see this all the time with like senior NCOs. They know they have something going on with their feet. They have a lot of foot pain or foot and ankle pain, things like that. It's probably like in many cases plantar fasciitis kind of stuff, which I know there's a whole conversation about. Is that the correct term for the diagnosis of whatever it is? I'm not an expert enough to have that conversation, but like prognosis for that is pretty good if you get it addressed early. Prognosis can be pretty bad if you let it go for like a decade and now you need a fasciotomy later in life and now you might not be running and have all sorts of limitations and stuff. So I know people picture prevention as do these things and you'll never have a problem. But like you said, a huge part of this is the secondary prevention where we're trying to catch things early and prevent them from getting worse.
Yeah, I agree with that. I think the access to care is one of it's not particularly well studied, but it is key, at least what I've seen in my clinical experience. Historically, getting into like a military treatment facility takes about 21 to 28 days. Versus with H2F, you're typically getting in within 7 days. Now that's historically, I don't know what's changed. Maybe the MTFs have been able to get people in quicker with more sick call and with the transition to DHA. I'm not fully sure on that. However, what I will say is if it does take 28 days for you to get in, for an injury, no longer are you acute in that.
Mm-hmm.
You're either subacute, or if you waited a little bit longer, you could be in that chronic state already, which may pose a risk for long-term rehab and kind of long-term progression. Unfortunately, not being able to get back as quickly as you would have hoped.
Where do you think, I want to ask this question from two directions, and maybe both of you guys can speak to this, but like, where's the biggest misconception from the soldier i.e., patient, to the PT in terms of the whole injury, quote unquote, prevention process? And then the second question is like, where does that, what does that look like from a leader down to the PT, if that makes sense? Go with soldier first.
Yeah, I mean, I guess.
Like, let me rephrase that. Soldier gets hurt and or has an injury previously and just has been living with it. In my experience, there seems to be sometimes there seems to be a bit of a misconception or a misunderstanding of the role that the PT is going to play or can play or should play. So what does that look like in your experience?
I think it's different for different units, at least what I've seen. One of the things I think that is super important is having leadership support. So if they know that the resources are there, they're going to support their soldiers being able to actually seek out treatment, which actually gets them in a lot quicker. Um, what I've seen is the soldiers who don't necessarily know that the resources are there, or they feel like they have to go to the doc or the PA first. Typically, those are the ones who may not. First of all, they're not getting treated as quickly as they otherwise would be if they came directly to us. And then also they may have kind of some more of those like chronic injuries. They might necessarily not be seeking out the physical therapist or the strength coach like the other guys or the other soldiers would have. Yeah, I don't know if I'm kind of answering your question or not.
Well, let me
I
ask it from
guess,
the leadership
yeah,
standpoint because I think this gets to what the whole genesis of this conversation, which is defining injury prevention. And I know you did a blog write up that kind of talked about this too, but what do you, in your experience, what have you seen like senior leaders assume injury prevention means and can do versus what it actually looks like?
oh yeah, that's a great question.
Thank you.
Yeah, of course. Again, injury prevention, kind of going back to the buzzword, one of the biggest things is injury screening. Hey, is there a 5 item test, subjective or objective thing that we can do to identify risk? That briefs super well. Unfortunately, not particularly well researched. That's one
Mhm.
of the things. The other thing with injury prevention, and this is like kind of the good stuff that's happening, and this is like the collaborative efforts of H2F and other human performance teams around the Army, but being able to use a wide variety of clinicians and subject matter experts to provide like care for the soldier as a whole and not necessarily just focusing on kind of like that biological problem per se.
Let's talk about injury screening because I know you and I have talked about this offline
Sure.
quite a bit.
Mhm.
Um, I think all of our experiences with this have been something along the lines of high-ranking person X decides that product Y looks really sexy, and salesman Z presents high-ranking person X a series of graphs and charts and lines, and they say, if you do, I don't know, let's just make something up, this force plate jump, then we can predict injuries in all of your, I don't know, let's just make something up, paratroopers. Um, we all know that that's bullshit, but can we kind of speak to maybe what true screening should look like or how it can be done well? Or can it be done well?
Sure. Yeah. Two schools of thought. Some people are like, just throw it out. Other people are like, hold on, this actually could be helpful. Don't just completely throw it out. I think the key to it is simplicity. I mean, we could make a 30 item questionnaire that looks at the extensive history of the patient's, health. But is that going to kind of help us predict injury risk? Really, I think the best question that you can ask is, have you had an injury in the past? And then follow it up with, did it fully resolve? If it didn't fully resolve, then address it right then and there. If it did fully resolve, let them know the resources to be able to readdress it if said problem comes back. One of the biggest things that we know is like a previous history of an injury can lead to another injury. So I think if you keep it as simple as that, you will honestly be able to catch a lot of those folks that might otherwise, slip through the cracks.
I want to double tap that because you mentioned previous injury is the leading indicator of, potential future injury. I don't know if there's a question or comment or talking point here, but I want to repeat it over and over and over and over again because you mentioned simplicity. Like that's as simple as it can get. Hey, soldier, have you been injured in the past? Yes. Okay, cool. You're likely to. It just seems that as these types of embedded programs expand, there's this drive and this urge for more data, more information, more graphs, more charts, and let's overcomplicate the screening process when really it's as simple as that. Like, have you been injured in the past? Yes. Okay, cool. You're more likely to get hurt again.
So I want to talk about actions taken based on that information, though, because whether you just do an injury history questionnaire, or you do a force plate jump, or you do an FMS or an FMS light or an SFMA or whatever, pick your brand of injury risk, supposed screening, whatever. And what I'm concerned about with particularly like the conventional military population that we tend to talk about on here, there's you can collect all that information, but are is the performance staff or is the leadership in a position to take any real actions based on that information? Because if you get somebody's data from your awesome screening, but then you just send them right back to the same exact PT that everybody else is doing without modifying anything or individualizing anything, then there wasn't really any point to your screening. You were just collecting data for the sake of data. Like, how do we make better informed decisions based on whatever information it is we're going to collect?
Yeah, I completely agree with that. I think it depends on how many like folks you got in your brigade. If you got a 4,000 person brigade, then like getting everybody through force plate testing is probably not feasible, and you're certainly not going to be able to actually have any real action on that might be meaningful. Any data collection that you do might be great, might brief well, but I don't. I think it would be years before you can take that data and actually turn it into something beneficial. I think keeping it with like the subjective questionnaire and being able to one address the injury like right then and there, that's going to prevent a whole host of problems. And then I think this is just a mindset, just remembering that prevention is not just prevention of the injury, but also taking into account secondary and tertiary prevention. If we can allow the rehab providers, the athletic trainers, physical therapists to keep doing what they do best, which is treating soldiers and treating patients, then you're going to potentially get, one, you're going to prevent chronicity of injuries. And then two, you're going to allow them a little bit more bandwidth to actually see those guys in clinic versus having them do a bunch of different testing that may or may not necessarily be useful, even if it briefs well.
And my follow-up question is, how much better could we be with the information we already have without doing additional collection? Because we know like body mass index correlates with injury risk. We know that 2 mile run times correlate with injury risk. We know that like, deadlift percentage of body weight correlates with injury risk. We know like all of this stuff from metrics we already have can tell us a little bit. Could we not be making better decisions about who gets attention and what kind of attention without doing additional data collection?
Yeah, I mean, well, let me ask you this first. Like you're naming off a bunch of different like risk factors. Have you seen like actual testing of said risk factors? Like if you address those risk factors, does that inherently reduce the injury risk? I don't know if
No,
there's
so
just
that's yeah, I have not seen that to be honest, in terms of like yes, we can say that after the fact soldiers that run slower are more likely to get injured in basic training or in their unit, but I have not seen anything in terms of test two groups of people, do an intervention that makes a set run faster, and then see if their injuries go down. I have not seen that. So
Mhm.
you're right. It's a correlation, not a causation. So I don't know if intervening on that is going to have the desired outcome on injury rates. I don't
I mean,
know.
it seems valid. But what I will say though is the 2 mile run time that they looked at in 2020 when they did the prospective cohort study, it was a 15:19. If they had an APFT 2 mile run greater than a 15:19, they had a potentially increased injury risk. Really, what they were looking at was a cluster of variables.
Mhm.
But that was one of the statistically significant variables, which I don't know about what you guys are seeing, but a 15:19 in today's army is pretty quick.
If you walk your 2 mile, like, okay, let's say that that's true.
That's fast walk, but
Well, no, what I'm saying is here's the issue with that kind of stuff, right? Is that you publish that data point. It's 15, 19 or slower, you're more likely to hurt. All of a sudden, that's like the thing. Not taking into account that the three of us could go out and walk 2 miles and take whatever, 20 minutes. some senior leader somewhere is going to tell us we're more likely to get hurt because we were slower than 15. It's like we walked, idiot. So that's sorry, that was aggressive. But like
I don't know what argument Drew's making right now.
my
I'm
point is that
confused.
like I think my point is that I think that injury prevention, quote unquote, and John kind of touched on this a little bit, and maybe we segue into this a little bit more. It is such a biopsychosocially complex concept to try to reduce it down to singular performance-based data points. Like you lose all of the babies and all of the bathwater in this pursuit of some
Mhm.
make-believe metric, which I think, Alex, to your point, is like most of the stuff we have already could probably tell the story that we're looking to tell. It's just this constant avoidance of addressing the complexity of what this truly means. And
Well,
that's the point I'm trying to make by walking a 2 mile.
you're also circling around the Goodhart's law thing that we talk about all the time here, which is, yeah, we can collect a bunch of data about people and see which correlates the best. But just because we go manipulate whichever one correlates the best
Exactly.
doesn't mean we had a good understanding of the complex interaction of the system. Yeah, absolutely.
Mhm.
Can we predict injuries?
Can we predict injuries?
Yeah.
Well, you that's a great question.
Thank you. It's two for
I
two.
guess I guess if you do take the study from 2020, uh you could have a basis for saying that there is some support that we can predict injuries for the specific like military population. If they had seven or more of those 11 variables, there was a specificity of 94% to help like rule in that they would eventually have. In regards outside of that's a great question, and it's again goes into the complexity of it, of how generalizable is it? What population are you asking for? What tests and measures have looked into it? What I can say though is that if you're looking at just can we prevent injuries, I think the better question is spend your time on focusing on kind of like that biopsychosocial model and being able to address the inherent problems that may be already going on within the unit. Like, is there current leadership trends that lead certain soldiers to be more prone to injuries? That plays a role in injury surveillance, which has been one of the important facets of injury prevention for 14 years, ever since this research started back in 2010. Additionally, like, do soldiers have appropriate load management, or are they just overdoing it? Do they have a regular maintenance of workload over time, or is it super high one month, super low the next month? I think all of those things are going to play a little bit better of a role in being able to predict injury. I know that's not the answer you're looking for, but I think it requires a complex answer um, instead of just a simple yes or no.
Hmm.
Just a quick one because you brought it up and it's something I've come back to a million times, and I haven't yet figured out a way to make it like resonate with people on social media. But as far as I can tell, not a professional in the space, but nerded out a bunch. Uh,
Stayed in the
like
Holiday Inn last night.
acute to chronic load ratio seems to be one of the better training related risk
I
factors
don't
for
know,
injury.
man.
Was that
But
the 0.8 to 1.3
it's
Yeah.
exactly what it is. But
variables? Yeah.
at the same time, I see pretty smart people like pointing out like flaws and fallacies in that argument. Like we talked at the top of this about like the semantic argument around injury prevention versus injury risk reduction, and I always point people to the Impellizzeri piece, breaking that one down from like the background of like broader epidemiology. But the same guy, Impellizzeri, has a pretty strong argument that the load management thing is also kind of bunk. So I don't know how seriously to
I don't
take the zero point 0.8 to 1.3 thing.
I've never put any faith into acute chronic work. I mean, because that only works when you can actually calculate load. So I get it from like, I mean, so right now, Tour de
Sure.
France is going on, right? The cycling community, very, very good at calculating these things because it's a very mechanistic single modality, whatever. I would make the argument, and you guys can disagree, that tactical athlete training is more akin to like CrossFit, mixed modality, whatever. And we've all seen people out there try and calculate workload for that type of training. Like you can't do it.
Well,
So that,
let's forget the specific zero point 0.8 to 1.3 and let's forget trying to quantify load in a consistent trackable way. And let's just say we get the overall principle that big spikes in training load lead to a higher risk of injury for the subsequent month or so. And we can learn that lesson without getting really scientific. For example, I'll just use the one I see all the time, which is unit goes to a CTC rotation or unit goes on block leave, or for some other reason, PT is disrupted for multiple weeks at a time. They come back from that, and some well meaning leader is like, all right, cool. We've been slacking for a little while on the PT thing. We have to make up for lost time. Here's the hardest workout you've ever done.
Hmm.
Like that's a fantastic example of the opposite of load management. You know you've had a layoff from training, which would indicate based on acute chronic load ratio that we should ramp back into it gradually to minimize injury rate. Instead, we're going to spike load as hard as we can to quote unquote make up for lost time. We didn't need any wearable metric data to track load to realize that's stupid. We can just teach leaders that lesson.
I've seen it done with session RPE, which I think is kind
Mhm.
of similar to what you're doing. And I've even done that in the past too, where like asking guys to put sort of a quote unquote session RPE on like a training evolution. And I think in that world, if you do see things trend high for a long period of time, then yeah, absolutely. I think you can make the case. But it's when people try to like strong arm stuff into that 0.83 number, where it's like, just stop it.
Yeah, it's not realistic in our
Yeah.
environment.
I'm a big sucker for auto regulation. I
I
love
know
it.
you are.
It's it's
We
good
spent
stuff.
many miles talking about autoregulation.
I know I've come a long way to finally agree with you, and I wholeheartedly support it. I think it's key for rehab for fitness. It is hard. It is a learned skill as well.
Yeah, but it should be. I
It
mean,
should be.
it should be. I think that effective training should be something you have to apply yourself to. So I think too often people just assume you can just stupid your way through a workout or a training plan or a patient provider relationship. And like, no, you should be engaged in it. You should learn something. That's just me.
Yeah, I agree, but
Do you
that's just not.
think, so let me ask injury prevention. Is it less because I think when people conceptualize it, they think of it as something that is happening between patient and provider on a treatment table. That is injury prevention. And I think truthfully what it is injury proofing, so to speak, the environment around the athlete on a continual basis. Like some of the things you mentioned and some of the things we'll probably get to talking to, like injury surveillance, chronic workload, all of these things. Like that's not something we put a splint on or wrap tape around. That's more of a multidisciplinary approach to changing the environment so that we don't get to the treatment table and the supposed patient provider relationship.
Yeah, exactly. I agree.
See, and I didn't go to
And
PT school to learn all that. I just sort of picked it up.
yeah, exactly. In an effort to not reiterate kind of the stuff I've already said, like talk about, education of the soldiers in the unit, that's super important. Leadership support, injury surveillance, all those are key things. The other thing is, improving physical fitness and progressive loading, and who's in charge of that. That's what at least what we're potentially moving towards with this human performance model is letting the strength coaches actually be the subject matter experts and be able to actually control at least the physical training element. They were huge, absolutely crucial in regards to at least my experience in trying to mitigate some of the problems that we were seeing. And generally, folks that actually worked with the strength coaches and follow their program we saw less injuries from them than we did from those that didn't.
Mhm.
And that's kind of just like observational data from the system that we used at my previous job, but it was pretty significant comparing the two. So being able to use those resources, I think, is crucial. It's completely most of injury prevention is honestly outside of the clinic.
Mhm.
So you talked about injury prevention being outside the clinic. I think we're circling around two topics here. One of which is like interdisciplinary, or in Drew's words, performance peripherals contributions to injury risk,
I
like
love
sleep
that.
and nutrition and things like that. I think we'll get to that in a second. But since you brought up strength coaches, and the question at the root of this is like, to what degree is injury prevention just smart training? I want to ask both of you, because I think you both have a little bit of experience with this one, what you've seen in terms of injury risk in three types of training. Injury risk when training is directly led by an actual professional coach, injury risk when training is designed by a coach but led by somebody who's a non-professional in the space, or injury risk when training is neither designed nor led by a coach. It's just soldiers left to their own devices figuring out training. How much predictive value does just that factor have in terms of risk of injury?
I think coach led would be the least likely to create injury. The second one would be the second least likely, and then the last one would just be a free for all of
But
injuries.
compare that to other fact, like how important, like is that a big influence on it, or is that just a minor factor in how much injury risk there is?
I think you have to ask what the current environment is and what
Mhm.
soldiers are leading it. Because there are certainly some very knowledgeable soldiers who know how to program, like a strength coach.
And there's some
Um,
bad strength coaches that are likely to injure people. I mean, that's not like to piss anybody off. It's just sort of the spectrum.
Sure.
yeah, I agree. I think in general, like injury prevention, I think it's min to mod effect. I think that the
Say min to
one
mod.
Yeah,
min to
minimal to
mod,
moderate. Come on, man.
Yeah, I know what it
yeah.
means. I've never heard anybody feel a need to like shrink it down.
And the only reason I say that is because of the complexity of injuries and what we see. I mean, there's like you also have to take into account the responsibility of the individual. What are
Mm-hmm.
they doing to prevent undertraining? Like I would argue that's probably one of the most important like modifiable things that you can do to prevent injury risk. And that's in addition to other modifiable risk factors like poor sleep, poor nutrition, poor BMI, all that kind of stuff. There's a significant responsibility held on the individual that you know regardless of what the guy leading PT is telling them to do, they may be prone to injury no matter what their because of their current lifestyle. That's kind of I think that would be the bigger thing to ask, though much more difficult to implement widespread individual change than it is to implement programs like this.
But I mean, to the point of the question you're asking, I think on aggregate, having someone with more experience leading a session, you would expect that the risk of injury would be reduced. You'd hope that the risk, but I
That leads me to
think
like wonder about long term, like what's the dose response of coaching almost? Because in this world, we don't have enough coaches for every session to be led by a coach. So like I would love to see something, and this is like really hard stuff to collect data on because you're working in such an uncontrolled environment. But like if somebody has a coach led session once a month, does that influence PT the rest of the month? If they have a coach led session once a week, does that influence
like
PT?
what's the minimum effective dose?
Yeah,
I think the biggest confounding variable is going to be education of the population.
for sure.
I
And
mean,
then you also have the question of like, do people gradually become autonomous? But that's hardly relevant in an
that would be an
organization that change
interesting,
over a third.
I don't know how you would study that, but it would be interesting to see like the causal relationship between like an increase in education, like physical education by some metric, and like you'd assume a subsequent decrease in the need for face-to-face coaching. Which, I mean, the danger there is what we're already seeing, like organizationally thinking like, oh, we can just like make everyone smarter, then we don't need coaches. It's like, well, that's not true.
It's only true if you're willing to invest the amount of time it actually
Right.
takes to create
To,
somebody who's competent. And
to change a culture.
we don't have time on this. I've been simmering about this for the last week. People who follow the social media know we've talked about it with resilience and fitness. But like the military insists on lying to itself about its own ability to manufacture experts. Like surely like maybe 2 weeks wasn't enough to create an expert. We can do it in like 4 or 6 weeks, right? Like that'll do it.
Yeah, but
Like
look at our cool facility.
ah,
Mhm.
Yeah, bless their heart. I do though. I mean, because this is something we're sort of getting at. I want to talk about the relationship between a strength and conditioning coach and a physical therapist slash we'll include athletic trainer here. That relationship as it should be in like a return to duty timeline. So like soldier gets hurt because I think what I see, I think you guys see this too. There's a lot of siloing of efforts and there's this sort of like line in the sand handoff from a physical therapist to a strength coach. And I know for me, and I know like we've talked about this on Mops and Mo's, but like how do we push that forward to make it more of like a multidisciplinary thing? Like what does that look like to you?
Yeah, I think we'll take the example of like long-term injuries because generally those are the ones that are going to work with everybody. Day one on your initial eval, you introduce them to the team and you collaborate to make a plan of care. So if they have lower extremities affected, they can typically lift relatively non-inhibited upper body. And if it's just one leg, they can generally train the other side as well to kind of have some of the contralateral neural effects. But I think not to get too nerdy about it, you can engage with the strength coach, the dietitian, the cognitive performance specialist, whatever have you, day one. It doesn't have to be solely rehab because generally, if they're not working out like they were before, they're gonna have to change their the caloric intake. If they, this may be a significant setback for them uh, physically. They might have really put a lot of focus into their physical performance and into physical fitness. They may need to kind of work with the cognitive performance specialist to address mindset and the other great things they do. Can't fully speak to it though. And then I think the last thing is maintaining a good relationship with them and formalize touch points. I think it's really important on the performance team as well to be able to discuss these at least once a month or something like that to generally follow a normal plan of care. But I think the longer you wait to engage certain subject matter experts, the less likely you are to actually use them.
Do you think that, and I'm asking these questions and I have my own thoughts on them, but let's trigger some people. Do we think that physical therapists have something to learn in the field of strength and conditioning? And do we think strength and conditioning coaches probably have some things to learn in the field of sort of PT?
Sure, of course.
Where do you think the biggest gaps are in both directions?
I think for physical therapists, just
Like where are we at
I
in
think
terms of
I
like
think
having
I think
somebody
you
stand
can
on a Bosu ball?
humbly remind yourself that just because you have a doctorate doesn't make you an absolute expert. There are other people that know a lot more than you and that
There
you
we
should learn.
go.
I'm a young clinician, don't get me wrong, so I'm still pretty dumb in regards to the things that I do. But you're never going to find me not asking a strength coach for their advice on a specific exercise or how to progress certain things because that's not better for me and that's going to affect the patient in the long run. So put your identity, put your pride behind. I think for the strength coaches, one of the biggest things is communication with the rehab team. Like, what do you know well? What can you do well in the rehab like side of things? Um, and then questions about how to progress. Like generally, like physical therapists are so quick to give all these precautions to strength coaches, but the strength coaches may know those precautions, um, or they just, might want broader left and right limits versus a specified plan for them to do. I think that, I can't really speak to the strength coach experience. I think people can learn from each other. Um, but generally, I just ask them if they're comfortable with the certain patient or not. I think
Well,
that helps.
I think that, and I know Alex, you got a point to make, but like just real quick, I think this gets to what we've talked about. And the reason I'm asking these questions is because I think this gets to what we've talked about a number of times specific to strength and conditioning, which is that as a coach, you have to put yourself on a level to be able to have that more nuanced, I would almost say like medical conversation with somebody like a physical therapist so you can understand those regressions and you can understand the nature of an injury and what that really means versus hearing somebody has a lower body injury and being like, okay, we'll still do squats. We'll just squat lighter. It's like, well, no, that's not like what we're getting at. So I'm glad we arrived at that point because that was sort of where I was headed with all of that.
Well, where I wanted to go was re-inject a little bit of like the responsibility of the individual involved. And I want to do kind of like two versions of scenarios you might have seen as a provider. Um, and I've certainly witnessed both, and I want your thoughts on like how frequent they are and how you navigate them. But one is, and I'll preface this by saying I try to explain to people, and you can tell me if this is like completely stupid, but I try to make them think of physical therapy like music lessons. You're probably not going to get a bunch better during the lesson. You might. There are certain interventions that can be done like on the table and certain injuries that are responsive to certain acute interventions, whatever. But in most cases, the clinician's job is to assess where you're at and assign you the appropriate things to do between then and the next time they see you. And you get the scenario where you give them a bunch of good stuff and you talk about it and they seem super motivated and then they come back in and they've forgotten the exercises you told them about last time, so they clearly haven't been doing it in between. Like how do you navigate that situation? And then I'll talk about the second one.
Ah, I love that you brought that up. I was at a course this past weekend, and I'm going to butcher what the instructor said. But basically, he was like, you can give patients what they want, and then comparing what you can give for patients what they want and what they need. If you give a patient what they want, but it's not necessarily what they need, they're going to do it. But if you give a patient what they need and they don't want it, they're certainly not going to do it. So being able to bridge that gap, one of the biggest things I've learned, and they told us this in school, is don't give more than like 3 to 5 exercises. They're exhaustive, and I don't necessarily know fully how this works. There's probably some reasons for insurance and stuff to make sure you get the full amount of time doing your 13 to 15 banded exercises. But if I'm never going to give a patient more than 3 exercises, the other thing I think that is super important is getting the patient buy-in, and that can happen on the table. That really happens a lot with the communication. It's pretty amazing the changes you can see if you make a bond with the patient. Um, because to be completely honest, most of the treatments we do, even if you're in completely different schools of thought, the patient's probably going to get better. So
Bless
just
your heart.
because you might be an expert in one specific sect of physical therapy doesn't make you really that much better than the new grad or the guy who's been practicing for 50 years. The patient is going to get better generally.
Yeah, what he's talking about there is natural history stuff, and you lose a lot of like you start to wonder how much is placebo when you look at natural history of various injuries. Um,
Oh, yeah. Oh, yeah.
you're you're like give them enough of what they want so they do what they need kind of stuff rings true. It's the strategy I've been using on the social media account because like divisive content and memes do better than anything else I post, and it takes almost no time to create. But I want to like I have this dream of like people actually learning something when they're coming to Mops and Mo's. But if I just post like straight educational content, we'd have no engagement.
No
It's
one cares.
horrific. But I do want to ask
Yeah.
about the other end of the spectrum in terms of patient compliance, because this was like this is personal experience from my own ACL rehab. Um, and without naming anybody, right? But I was assigned to a physical therapist whose like thing that they loved was e-stim for like getting muscle activation back when people were struggling with it after surgical
Mm.
interventions. And I had done like a ton of prehab work, which we can talk about the concept of prehab in a second. We've skipped over that, but I had done a bunch of prehab work before surgery. When I woke up from surgery, was still like on all the meds and stuff. I could already activate my quad right away. So he was super disinterested in me. So I would do all my exercises, but they just like hand me a sheet of paper with a bunch of exercises and send me to the other side of the room to go figure it out. And like nobody ever monitored me really. I think I saw the physical therapist for like a total of 15 minutes in the whole rehab process over the course of months. Like, and I ended up having to go seek out like off base help from physical therapists who are friends of friends or whatever, who like sat me down and explained movement quality because I could technically do the exercises. Like not that many weeks after surgery, I was doing single leg squats on a Bosu ball with a different weight kettlebell on each hand. And I was technically doing it. But if someone who cared had been watching me, they would have told you have like no control, dude. Stop, like back up. How do you handle the other end of the spectrum with like patients trying to do more than you need them to do? Or like, I don't really know how to describe that, but it's the opposite of the patient who's not doing any of the exercise. It's the patient who like needs to be held back, probably.
Oh, like pumping the brakes. Yeah, that's that's the population I treat now. Uh, everybody's going 110% all the time. Um, it requires a pretty extensive look into like what they're doing in their training in the field for their physical training, what their sleep, what their nutrition looks like, and we're much quicker uh, to send people to kind of work with other experts if one of those things needs to be changed. One of the big problems I see with the current population I treat is they'll get to about 90%, right? And then they'll just go back and hit it hard in the gym, in the field. They may re-injury, they may re-injure, they may stay at 90%. And I don't want to go back into that, acute to chronic workload ratio. But these guys are working, oh my gosh, way, way more than the general population and most folks in the Army. Um, I mean, again, communication plays a key role. And then this is one thing actually that is important in the research, and this has been shown to be ineffective, is just adding on extra stuff to what they're already doing adds no value. And this is more for like conventional Army specifics. But if you take if you are able to seamlessly integrate rehab and prehab into what they're already doing, generally they're going to one mesh well with it because they get to keep doing what they love doing, and then two, you're going to prevent overtraining or overworking, and that's kind of some of the other things that you may see.
The talk about things ringing true. I use this example all the time, but in college, I hurt my ankle. I get a pretty severe ankle sprain. And then like years later, I tore my ACL and had to have surgery on that. And you would assume that the ACL one would limit me more today. It doesn't limit me at all. I don't think about it ever. It doesn't like it hasn't affected range of motion, strength, anything because I rehab that one properly, but also patiently. The ankle, I did the thing that you've described where I was kind of patient up until the day they told me I could start running again. And then I never went to any kind of appointment or did anything else again because the army had convinced me that like if you can run, you are healthy. There's nothing else to think about in terms of rehab. So the moment I could at least like run in a straight line and like not even thinking about change of direction or balance or anything like that, as soon as I was like, all right, cool, I must be healthy, forget that rehab stuff. And now like 10, 12 years later, my ankle is still a limiter for me because I didn't invest in the time like when I should to address those limitations. But
Yeah, I generally try and I think it's a good practice to schedule a follow-up if that guy, or like for you, I would have been like, if you had just started running, is that your situation?
yeah, as soon as I
Yeah.
was cleared to run, I forgot about anything rehab related.
Yeah, I mean, it takes 15 seconds. Like, hey, 3 weeks, come back, see me. We can take 5 minutes, chat about it. Let me know how you're doing. Like, if you can do that, I mean, I'd imagine that like one, the patient's going to appreciate that, and then two, you're actually going to be able to see if they truly do get better versus just sending them back to the bottom.
I think there was just too much volume at the time.
Alex wouldn't have shown up to his follow-up.
I mean, that's possible. Who knows at the time?
He'd be like,
That
nah,
that's at that point, that's
screw that
that's out of my
guy.
hand.
Oh, I know
Yeah.
the ankle is all my fault. I don't blame any physical therapists for the state of my
You should go back and ask that Eastham guy if he can fix it up for you.
ankle. Well, I do want to like eventually
Do some
like
FMS.
because I've been told because I've had people look at my ankle, army physical therapists and civilians and stuff, and like the first answer I was given was that like although I have slightly less range of motion in my right ankle than my left, it's still like certainly meeting standards of normal, so they're not really worried about me. But I would love to eventually get all of that range of motion back. But the work you have to do on that stuff, especially if you didn't handle it at the time when tissues were remodeling, is so boring
So
and
you don't want it. You
so
don't want it that bad. Is what you're saying?
like it's just like it just takes so much time and you have to do it so often for so long and it doesn't feel like working out. It's just like
Yeah, it's
chores.
awful.
Ah,
I get it. I completely get it. I told myself at the beginning of the year, I was like, I want to be able to like touch my toes without pain. I'm not a very flexible guy
John
for
is
physical.
one of the most inflexible people I've ever seen.
And I
I can
would
attest to this.
spend at least 30 minutes, sometimes up to 90 minutes, just static stretching, just holding it to see if that would do anything. But I quit after about 3 weeks because it was literally so boring.
it's
And
so
that's kind
tedious.
Yeah, that's kind of stuff you have to do. Like, I mean, how long
I
can you
love
do
it. I love it.
mobilization?
Scott,
Do you follow the Range of Strength guy on Instagram?
Oh, me?
Yeah.
John doesn't have an
No,
Instagram.
no,
Ah,
I don't.
the
I have a Goodreads and Strava.
I
He
wonder if he
just got
has
Spotify.
I wonder if the guy has a website. I'm gonna see if he has a website because Range of Strength puts out some really cool mobility. Yeah, he's got a website. He's Canadian. Oh dang.
Mm,
No, he's got some stuff on here. He's probably got some programs. The dude is doing some pretty cool stuff in
nice.
the like hardcore
Check it
mobility
out.
flexibility space.
See, people like that, and there's a few of them, and I'm not going to knock him. Good for him. They just piss me off though, because they always post these like, I mean, for lack of a better term, circus tricks. And I hate saying that
Mhm.
because it's impressive stuff. But then what happens is it throws a wrench in your whole philosophy about training. And then the next day you're in the gym and you're like, I need to throw it all out. I got to start fresh. I got to do single leg, split squat, barbell overhead, ring muscle up, whatever, whatever.
Hmm. With the bamboo bar.
Yeah, exactly. So I just choose not to engage. I just do yoga.
That's the downfall of like the whole social media fitness world, right? You have to do extreme stuff or post things that are
Well, my
divisive or whatever to
question
get
for those
attention.
people is always like, and I mean, Alec Blennis, he's less guilty of this, but he does post some wild stuff. And it's like, what is the progression? Like, throw that into a training plan for me. Like, what does that look like in a training
Sure.
plan? Like, if it's just if part C of Monday is just like fuck around time, like great, cool. But like, show me your training plan. That's what I'm
You
curious about.
you know the answer
Mostly
to
so I
that
can
question,
steal
right?
it. Mostly so I can steal it. What's the
You
answer?
know you have to pay them for that part.
Of course.
Mm,
Yeah.
And that's where I draw the line. I'm not,
those
no,
are the
I'm
secrets.
not gonna pay you. I'm not gonna pay you. I'll just mess around and see what I can do. But rewinding a little bit, I've done yoga with John before, and it's not good.
That's hard. Yeah.
He's
Breathe
not
and
pretty.
flow. Check him out.
Oh, that's true. The good old days. Hey, where do we stand on prehab?
Rehab. Oof. Good
Prehab,
question.
short for prehabilitation, short for I don't know. What even is
Mhm.
prehab?
I I like it. I
What is
generally
it?
use basically what
Warming up?
prehab, at least what I see it as, is a way to uh yeah, I guess it kind of goes into the warm up.
It's just a warm
Um
up, isn't it?
it's pretty much a warm up.
Alex, what's prehab?
It's pretty much a fancy term for muscle priming warm up.
Well, so we're getting into like the space of like corrective exercise now, which I'm curious about your thoughts on that term. To me, what prehab means is face pulls. That's like the one guaranteed.
Mm,
Like if you do enough face pulls, your shoulders will be bulletproof, right? I think that's
They'll
a
be
thing.
prehabbed.
Have we studied that?
Bulletproofage.
mhm. Extensively.
And
Bulletproof.
then tib raises are proven to bulletproof our knees. We
Hey,
know that
I've
as
been doing
well.
a lot of those, man. The tib raises are the front of my legs have never looked so.
Yeah, how do your knees feel?
I mean, they feel fine.
So the same?
Fine. The low back is always the issue, but the tib raises don't tend to help that.
You never really know until like you catch a stray bullet in the knee and it just bounces off because you've done enough tib raises.
Hmm. Well, okay. So amidst the banter, I think maybe the question here is this: like correctives, prehab, whatever the hell buzzword we want to utilize. My experience has been that what tends to happen is somebody just wildly deviates from the plan that they had been doing and starts doing a bunch of that stuff, because they saw it on Instagram or whatever. And I've been guilty of this. And by doing so, they end up absolving whatever issue they had. Let's call it knee pain. I think it's less the prehab and the correctives and more just the deviation from the training that they had been doing. They could have been doing whatever else, but because they did bulletproofing or prehabbing or that all of a sudden becomes the thing that they swear by, and then they turn around and try to sell it or proselytize it towards everybody. Does that make sense? What I'm getting at with that?
Yeah, I think you did hit at an important part though, is once they believe
Oh,
that
that's
it is
true. Yeah.
the thing that helps them, like that's pretty powerful. And if they believe it so much that they're going to keep doing it to help prevent like that pain from coming back, by all means. I mean, that makes my job so much easier.
Well, let's talk about placebos because I know we've had these conversations before, like foam rolling, for example. Like, where do you think For a modality like that, are we just wasting air debating whether or not the science backs it up if the athlete thinks that it makes them feel better? We've talked about this with ice baths and hot, sauna, whatever. I have changed my mind on that a lot in the last couple of years, which is to say that if rolling around on a foam roller makes you think that you're better, then by all means.
I think there's a value to foam rolling. I think if I'm going to give it to like to a specific patient, then there's a time and place for it, and there's usually certain things that I look for that might indicate that. But I think that goes back to kind of the prehab stuff. Generally, it's got to be pretty individualized, but there are certainly things that you can give out to uh, kind of like generally to help strengthen certain areas that are generally weak in lots of people. Um, but I will say placebo is super powerful, and it can be even more powerful once you get the athlete to buy into whatever it is. Uh, I mean, I don't do ice tubs. I don't do sauna. I don't foam roll.
The fact you called it ice
I don't do
tubs,
any recovery. The only thing I do is a little bit of prehab before my workouts because to me that's what I feel like helps
you just
me
said
and
you
I
touched
me
your
help.
toes for an hour.
I stopped doing that. I did make progress, but I had to stop.
Okay, so this is
Um,
this is bringing up a few questions for me, and one I want to address. So you're talking about placebo, which we can acknowledge is a hugely important part, and there's like placebo gets tied in with the provider patient relationship and things like that. Where I start to worry is when like you acknowledge that there's a time and a place, and if the patient believes in it, great, and if it creates space for other things, great, and that's all awesome. But then we see things like a platoon or a company of basic trainees all foam rolling under an awning in the middle of basic training. Like I think anything that gets standardized across the formation, you immediately lose the placebo effect because they're not going to believe in it unless there's somebody doing like a fantastic hype man job somewhere. Like
I mean, you could,
where do we draw the line on like can we say this is fine because people might believe in it, but then we're buying thousands of foam rollers and having
yeah.
giant formations do it all at once. Like I don't know where the
Well,
ROI is there.
could you make the argument that some of the ROI has to do with the fact that this new army, whatever you want to call it, like is making time for recovery by virtue of a bunch of people dry humping a foam roller? Because I get what you're saying. Like, yeah, you lose the whole point of the placebo effect, but it's the same argument I made for like the Whoop. Like the data on the Whoop is largely bullshit, but the fact that you're distributing them and people are wearing them tells me that you care about
Yeah.
that. You know what I
Like
mean?
creating an environment where it's valued.
Yeah, it's
I can see
valued.
the argument. Yeah.
Sure.
I
Sorry, I
mean,
interrupted
what's the
John.
alternative for those folks at basic training? I mean, to the foam rolling session.
PRT,
Yeah,
Yeah, the alternative is
PRT.
more training.
just stupid stuff.
So like even if there's no placebo or the placebo is gone in regards to like the treatment effect, like generally the I would imagine that the feelings around foam rolling are going to be positive because like, hey,
Sure.
this is my time to take a break from the run of the mill stuff that we do.
Okay. I will say I got to defend the basic training enterprise from Drew's stupid stuff line there. I don't, and like John, you might know more about this than I do, but PRT has had its struggles in different environments, but PRT's implementation in basic training cut the basic training injury rate by like more than half, I think. Like it was a pretty incredible shift in injury rates,
Just
like
from doing the warm-up stuff?
from switching to some like first of all, PRT is not just the warm up stuff.
Sorry.
Basic training might be the
When I
one
meant
place to do it right.
PRT, I envisioned like whatever, plank jacks and all the random
Military
shit.
movement prep drill
All
one
right,
and two.
Yeah,
audience. Drew and I are
Army
gonna
drill one.
Drew and I are gonna go out back and discuss all the other parts of PRT that were actually pretty good.
please do because I
Um,
have no clue.
because there are like legitimately valuable things in there. Like nobody, obviously nobody did the climbing drills because nobody could do leg tucks. Nobody did gorilla drill. Like there's like resistance training was a component of PRT. There was like 6120s, 3060s. All these things are parts of PRT. If people had actually paid attention to what was in there, there was some valuable stuff. I don't think PRT was perfect for the whole army by any means, but it took basic training from like unstructured, random, whatever drill sergeants felt like kind of And there was previous stuff in TC 2120, and I'm sure people who know more than me are going to criticize me for how bad a job I've done with this. But like the implementation of PRT as we know it in 2012 was super beneficial to injury rates in basic training. And it's worth saying on an injury prevention podcast episode. So like to the extent that injury prevention is just intelligent training, PRT was a move in the right direction
I thought
for basic
PRT
training.
was just a warm up. Hmm.
That's what a lot of the Army thinks too, but maybe we need to do an
I did
episode on like setting
you
things
remember
straight.
doing the climbing, I think it's the climbing drill one. We did some pull-ups and stuff
Uh-huh.
a while ago. And then all the other drills I only see when I write profiles. Soldier
Mm,
cannot participate in movement, military movement, prep drill one, prep drill two. I have no idea how to do them then. Never
mm.
done them.
Yeah, people don't know. I mean,
Hmm.
guerrilla drill involves like a forward roll and a buddy carry and all this stuff. Like there's things in there that people have no idea.
Is this like the World War II calisthenics stuff that people love to?
Different breed of
Yeah,
folks.
yeah.
Guerrilla drill does get a
Back
little
in
bit into
my
that kind of
day.
space. Yeah.
And then
So
next thing you know, we're in
get
Normandy.
getting us back on the rails instead of going down a PRT rabbit hole. I have a direct question for John, which is, and I'm going to ask this a bunch of different ways and then provide like my anecdote that made me believe it's true, but I don't know if it's true. Um, are muscle imbalances a real thing that contributes to risk of injury? Is the whole push-pull ratio thing, like you could pull more than you push, is that a thing? And then like getting real specific, upper cross syndrome and lower cross syndrome, like do we think they're real? Where do you stand on that whole debate? And like I
Man.
asked that I used to be a big rock climber, and I ran into this issue where if I climbed too much, I would end up with elbow tendonitis. And then me on YouTube and Google or whatever, it tells me that I'm pulling too much and not pushing enough, and I've got imbalances. And when I incorporate more pushing stuff, I have fewer issues with elbow tendonitis. But maybe that's because going and doing upper body pushing just made me not climb for a day,
Hmm.
and that fixed it. So I don't know if it's real or not. I really don't know.
Yeah, okay. A lot of different things. A
I was gonna say you went all over the place there.
lot of hot topics.
Let's go
We'll
muscle
start off
imbalances
we'll
first.
start off muscle imbalances. So there are two ways to answer this question. One is I could, listen to what the gurus say on WebMD and whatnot. And the other one is kind of take a look at the research. And I am not a statistician, I'm not a big researcher. But what I will say is there is some evidence that kind of talks about muscle imbalances for like specific populations. One that comes to mind is for hockey players comparing adductor, like hip adductor to hip abductor strength. Generally, they found if it was under an 80% like strength ratio, they were more likely to get injured. But that was for a specific population and a smaller population too. What was the next one? Upper cross, lower
Push pull ratio is the next one.
push pull ratios. Oh yeah, yeah, I haven't really seen that one too much. But generally aesthetically, you're going to want to have it relatively even. But in regards to injury prevention, I can't really speak too much on that. What I will say anecdotally and in the clinic is that there are generally certain muscles that are generally not trained to the way you want to be because there are certain things that people do. Like it's international, like go into any MWR facility and it's International Bench Day Monday through Friday. So people are pumping, anterior like pressing movements and stuff like that. But how about the mid trap? How about the external rotators of the shoulder? How often are those getting addressed? How often are the hip abductors getting addressed outside of running and hip external rotators? Again, this is all anecdotal, some of the stuff that I've seen as weaknesses in the clinic. So I can't necessarily speak to what the research has to say. Um, but if you're going to hang your hat on like a push pull ratio, is like, if you're not doing that, that's going to lead you to injury. I wouldn't do that. I wouldn't put too much weight into that.
Well, that
Uh,
helps me. That helps me transition into the next question, which is the Yanda upper cross syndrome, lower cross syndrome stuff. And I'll tell you, I started to buy into it
You may want to
when I
explain what it
was
is.
okay. Well, John, do you want to explain what it is? Because you'll probably do a better job than me.
uh, Basically, upper cross, lower cross syndrome is one of these theories about posture causing tightness on one side of the body and stretching on the other side of the body, and they kind of collaborate to make your pain worse. I guess is what you could say.
I'll do the practical version as I understood it as like a not physical therapist who hadn't studied it very much. But like the upper cross syndrome was the one I spent more time on because you'll realize in a second it ties to leg tucks. But the idea is if you're doing a bunch of like anterior dominant stuff without a lot of like balancing posterior stuff, you end up in this kind of hunched position a lot, where the muscles anteriorly are stronger and tighter, and the muscles posteriorly are
Sounds
weaker
good.
and less tight, looser, and that contributes to some postural issues, which may or may not be related to pain and or injury risk issues. And I used it in these talks I used to give all the time because I found I could pretty successfully pick out people who struggle with leg tucks by just asking a crowd full of people, pull your shoulder blades together. And like people with pretty healthy, and we're not going to get into scapulohumeral rhythm because some of that stuff's wild, but like people with pretty healthy shoulder movement and stuff could like pull their shoulders back and down pretty well. And I wasn't worried about them. And the people I worried about either pulled their shoulders like straight up and were like super tight, or they like lacked the neuromuscular connection to even like control their shoulder blades at all. And consistently, those are the people that would struggle with any kind of hanging from a pull-up bar type of movement. And we saw like the most egregious example was a guy who like loved benching and rucking to the point that, and we did refer to this guy to neurology, but he like had lost proprioception in his hands. Like he didn't know where his hands were unless he was like looking at them and would like drop stuff if he wasn't thinking about it.
See a Marine.
Uh,
How
no, this is
often
an
did he
army. This is an army guy.
Hmm.
What's up?
how often did he ruck?
He was really into it. This was like multiple times a week kind of guy doing his
Yeah.
own thing.
Was he a sergeant major?
No, but he was, I think, at least like 87.
It was his 12 mile time.
Who knows? Hopefully pretty good because he was doing all that freaking
He can't
rucking.
start his watch. He doesn't. He can't use his hands.
Yeah, that's true.
Doesn't know
You're
where his
right.
hands are.
But
I
like
must
that
use my
seems to
hands.
contribute to an argument about like upper cross syndromes and patterns of tightness and weakness and things like that. So I don't like, but I also know that a lot of PTs say that's like completely made up and Yanda's crazy. I don't know.
Yeah, it seems like a pretty good audience trick. I'd be interested if you just did the whole thing. Hey, how many of you guys can pat your head and rub your belly at the same time, and then see how many of those guys can do leg tucks? Because I think you probably have similar
Sure.
responses. Um, I mean, we call them in the clinic motor morons,
Yep.
if that's like the term, but uh I think for the upper cross loader, I don't put really any weight whatsoever unless I can have a change in clinic on posture. I don't really
Sure.
think the research supports it all that much. I think it's kind of a throwaway one when you failed to address other problems that are easily testable. So you're just falling back on posture. Um, what I will say is anytime I've ever told anyone or like anytime I've seen a therapist like address posture as the main impairment, chances are that person's not getting better.
And the research is pretty consistent on that as well, just to back up what you're saying. Like there's a lot of people who will tell you that like posture is super predictive of injury risk, or like bad posture is going to lead you to bad things. And there's no serious research that I've seen that can even tell you what good or bad posture is, or tie any particular posture to injuries, to include things like text neck or sitting too much and things like that.
But Kelly Starrett said, and so do chiropractors.
Yeah, Kairos are master businessmen.
I want to say something on here. I haven't been ready to say this on Instagram because I've noticed.
So you're gonna throw it out on a podcast?
Yeah.
Okay,
Because
cool.
I the audience here is more nuanced. We're doing long form stuff. They've committed at this point to listening to at least this much of an
They're an
episode.
hour in.
I've experienced a significant increase in recent weeks of the number of chiropractors that follow me on Instagram and like share my content and stuff like that. And I'm not totally sure how to feel about it. Um, I've worked with like a couple chiropractors that I really like. We've had a chiropractor on the podcast that I like a lot, things like that, where I have issues, and I'm just gonna like state this real clearly, and somebody's gonna get mad at me. I really don't like chiropractors that put doctor in their handle because they're very much trying to get people to believe they're a different kind of doctor than they actually are. And that frustrates the
Mhm.
hell out of me. Anyway, that has nothing to do with this episode, but
I think that's great you say that. I think the
What
reason they
about
put it is
PTs that put doctor in?
this is going to get me some flack. I hate it. I will never do it unless I were to go get a terminal degree. It isn't DBT is an entry level degree. That's just me. That's just me and how I feel, but you will never see me put doctor in front of my name.
Hey, while we're
Uh,
at it, it drives me crazy when strength coaches put more than just CSCS and MS if you have a master's. But
oh
man,
yeah, that's just LinkedIn. That's just all LinkedIn, man.
we should do a LinkedIn episode.
Hold on. Before we do a LinkedIn episode, I'm just going to quickly look up Drew on LinkedIn.
MS,
You got a
CSCS.
few letters.
Yeah,
Drew's
MS,
got a few letters.
CSCS. I'm talking
What makes those letters acceptable?
one is a degree and the other is like
Mhm.
the industry standard. It's when you got folks with like functional movement level 3, CrossFit level 4, blah, 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 bullshit, bullshit, bullshit. It's like every weekend cert you've stacked up. That's
I
when I'm like, all right, come on.
I feel like the reputation you have developed would speak more without the letters than it does with the letters.
That's fine. I'll take them off.
Okay.
We should start a LinkedIn movement, like hashtag remove the letters or something.
I like
Just
I
get
that.
feel I
people
feel
I
to,
love
weird
that.
because I tag Drew on LinkedIn posts sometimes when it's mops and mosey kind of stuff, and I feel weird seeing those letters pop up when I tag him. It's weird.
well, we've already talked about
I
how I'm
do. I
gonna,
do want to say. I do want to say. I have. I have dear friends who have no problem putting doctor in front of their name, and you know what? That's great. But I will never do it.
if
I
you
think it's
can't save someone on an airplane, you should not be able to put doctor in front of your name.
well that runs. There's a whole host of people without doctor in front of their name that can save people on an airplane as
Sure,
well.
but it shouldn't go the other way.
All right, but what about the you know the mathematician?
You're saying the mathematician that just has
The
like an
mathematician who went to
interest
Yale,
in medicine and decides to save
who's
somebody.
got a PhD.
No, he's talking about a math PhD.
Yeah, he
Like, should
shouldn't.
they
Yeah,
put
math
doctor in their stuff?
PhD. He's definitely a doctor.
I think we just need to change the name. Like maybe
Is
they should
it?
be wizard or something.
Well, here's
I need
no,
somebody with
no, my
history
favorite
chops
thing.
though.
My favorite thing I've seen is
We should
when
do.
like world-renowned orthopedic surgeons, what they sign their email as either their nickname or their initials. They don't
Oh yeah.
put
Hell
any,
yeah.
and that's it. They don't even put their phone number. They don't put any accolades on there.
I
That's
can
when
get
we know.
behind that. I can
Yeah,
get
I
behind
love
that.
That's what I'm saying.
Or just go the Air Force route and make up weird names for each other and put that in your email signature.
Call signs.
Tomahawk.
that.
Okay. Let's cut to the chase because we're getting close. I think we've passed an hour. But do we want to talk programming?
You can.
I'm just curious because we've kind of like we've circumnavigated, we've gone around in terms of like the philosophy, I think, on
Yeah.
injury prevention and all of the different things. And I'm just curious for a quick segment on like what does that mean for programming? And we will have already in the intro talked about the stuff that's on the site, but like just for you when you sit down thinking about training, injury prevention can be part of that, but more specifically, like getting into the gym, doing the thing if you have an injury or if you're coming back from an injury, like what's going through your mind?
Yeah. The first thing first is don't just throw a bunch of new stuff in there. The second thing is being able to have a moderate load that you can maintain, even if you're injured. There are certainly low impact options for cardio. There are muscles that you can work out. This is for most population who's injured. Generally, you're going to have one, maybe two injuries at the same time, still allowing you to work several appendages and core or something like that at the same time. So that's something to take into account. And then the other thing I think is identifying something that's going to allow you to stay consistent. If you're just trying things out to try them out, then you're probably going to have low compliance to what you actually need to do. What's going to actually get you back in the gym? What's going to get you doing some cardio, doing some lifting? I mean, there's a whole bunch of research that just supports general exercise to help with pain, especially chronic pain. So if those guys are just, still sitting on their butt, sitting on the couch, you're really missing out on a lot of the good stuff. And that's regardless of how great your programming really is. Does that kind of answer the question, or do you
Yeah,
need more specifics?
no, I think so.
Now, I'll ask a tactical question for somebody going through a rehab program. Should people trying to rehab an injury, whether they're working with a provider or trying to handle it on their own, do you do you avoid all pain when you're trying to rehab the injury? Do you push to the point of some pain when you're working with or around that injury, or is it something else?
I think that's a great question. And it
Hey, got one.
depends. It really depends. Um, there's some research that supports. I mean, a lot of the research was done with, for example, the Achilles tendinopathy that we'll take and apply to other tendinopathy things. This is just an example. You're able to work in the 3 to 5 out of 10 pain range. I know it's subjective and everything like that, but they've actually had good results working into a pain range for things like tendinopathy. Also for chronic pain, working up until like symptoms are tolerable, not exceeding that to put yourself in a setback or a flare up for several days. That's pretty important too. Generally, if you're kind of just avoiding pain altogether, you're not working at the intensity that you need to for some of the pain inhibition effects to come into effect. But there certainly are some diagnoses, injuries where avoiding pain is appropriate. I mean, if you got a fracture in your leg, and you think walking on is a good idea, especially if it's one of those high risk areas, I probably wouldn't recommend that. But generally, if you have even if you got the worst PT in the world, they're probably going to be able to tell you that that's a bad idea. Generally, a lot of people are very conservative, and against pushing it too hard too early. So I think and I don't want to spend too much time on it, but I think that's really important to actually look into the research in that and be willing to kind of push the patient. Generally, you'll have better outcomes and they'll appreciate you for it too.
It does seem, you mentioned that people are generally conservative. It seems like, from my outside perspective on the field of physical therapy and also just like orthopedic stuff in general, it seems like the field has moved towards more and more aggressive protocols, like less time in casts, less time in braces, less time immobilized, and introducing exercise earlier and introducing intensity earlier. Is that like an accurate read on the evolution of the field?
I think it depends on the injury.
Sure.
There have been some really important leaps in that area. For example, traumatic brain injuries. I mean, back in the day, you just spend 2 weeks in a dark room. You don't do anything. You don't go out. You don't talk to anybody. You just recover. Right. We've really moved away from that. Max you're really spending now is 24 to 48 hours, like where you're kind of secluded, and then you're getting back to stuff working at an appropriate intensity and being able to push it that way. There's a lot better effects on that. That's just an example. Um, yeah, there certainly are some more aggressive protocols. If you're looking like post-operatively, the research varies. Like I know there's some research that kind of looks into like quick rehab for ACL recoveries. You kind of look at like anywhere from 4 to 6 months. But I'll tell you that the research also says that if you're coming back from an ACL reconstruction prior to 7 months, you're essentially 7 times more likely to re-tear it than you would if you waited to 9 to 12 months. So again, you need to look at the research. You need to understand kind of what's going on. But I do appreciate how some of the research is moving more towards being less conservative and honestly like being able to accept some liability on your part as a clinician, and that's important. If you are a clinician, you need to be able to take smart and well-researched risks and better understanding your patients so that they can hopefully get quicker better.
Didn't Aaron Rodgers come back from an ACL in like 45 minutes?
Who's the Vikings
I
guy?
think it was Adrian Peterson.
So the core of my ACL rehab was watching Adrian Peterson highlight reels over and over again for like 6 months. And I told myself that as long as I wasn't MVP of the NFL, I was behind on my rehab timeline.
So you wanted to get back Adrian Peterson time?
Well, I mean, when you're sitting there, like when you've made your whole identity like outdoor sports and fitness and things like that, and all of a
Yeah.
sudden you're sitting on a couch with a swollen knee and like wondering what the hell your life is now, like
Adrian
you,
Peterson.
you got to keep morale up somehow. And the best way to do that is Adrian Peterson highlight videos.
It's fair. No, that's good.
I will
All right.
link the best one in the show notes. It's incredible.
Nice. Good.
You are part of the team now, but I still want to ask you closing questions. And I may know the answer to these. We'll see. Okay. There's two of them. What's one thing you've changed your mind on?
Broad question.
What do you say?
That's a broad question.
Hmm.
Ooh,
I mean, okay, fine. You can make it specific to injury prevention. I don't really care about like nutrition.
injury prevention. Um, I think one of the things that I have changed my mind on is there's a really big push for young, like, I don't know if you want to call them Gen Zers, PTs, to be like all exercise all the time. Um, I really do appreciate some of those passive modalities, the manual therapy type stuff. We can argue about whether or not it's super effective, but there certainly is some research just to, you know, suggest that it helps. Whether or not it's placebo or whether or not there's true neurophysiological effects. I really appreciate things like spinal manipulation. I think that's great. And that's like back cracks, some of the stuff that the chiropractors do. Generally, I communicate it differently than they will. So I'm not trying to sell the product, rather trying to use it as potentially a tool to address pain. I like dry needling. I like some of the different systems that physical therapists use in regards to things like repeated movements and, kind of, not necessarily just solely focusing on rehab. I do think that the therapist can play a really powerful role by putting hands on a patient as well.
What about kinesia tape?
Oof, K-tape. K-tape's so lame. So boring. I was telling a patient that today. I asked because he had K-tape done in the past, and he was like, did it help? He goes, no, actually, it kind of made it worse. I was like, good. I hate it. It's boring.
What about
But I'll
cupping?
do
What
it
about
if
cupping?
the I don't think cupping does anything. But I'd be lying if I said I didn't do it.
Well, yeah, I mean,
People,
I just remember Michael Phelps on the springboard or whatever, like taped up to his freaking neck and cupped that one Olympic year, and then all of a sudden it was the rage. I got to be
oh
taped. I
yeah,
got to be cupped. It's like, what are you doing?
yeah. What's the shot putter's name? Ryan Krauser, something like that. He's like the lead U.S. shot putter. Anyways, he had it on his non-throwing arm the other day, or during the U.S. trials, just on his tricep.
He was cupped or he was taped.
Yeah, he was cupped, not taped. I didn't see any
Jeez.
tape.
Okay. Second question, final question. What's one thing you've doubled down on?
Oh, zone two training, 20,
Hmm.
You
80,
weren't a
20.
runner when you started with me, though.
No, I was fat. I was
Yeah.
fat
Now
and
you're
slow.
doing all the miles.
I love 80-20. I think it is so easy. It makes my life easier to just follow a simple running plan, um, versus trying to make things super complex. And and yeah, zone two is a really good way to get to know people, especially when other
Yeah,
people
it's
around you
true.
like running. Um, I don't know, going out and getting coffee with the boys is that's not really something that happens, but like going on a nice like 8 mile run, that's a good time.
Fair enough. Awesome. Well, this has been great. Thanks for coming on. We'll mention stuff in the intro too. So in case you missed it, Alex linked the blog post in the show notes. And
We're gonna have all sorts of stuff in the show notes. We're gonna have the blog post. We're gonna have the Adrian Peterson highlight
let's
reels.
do
We're gonna
Heck yeah.
I'm gonna say this so we're committing ourselves to it. Let's do a little injury prevention FAQ collection there on the IG and we'll bring John back
that's a
on.
good idea. I can collect some questions from the
Yeah,
people.
let's get some now that we have a PT, let's do some PT stuff.
I love it. Yeah, this was great.
Make sure you get a computer that works next time though.
I have three to choose from. I'll make sure one of them works.
Perfect. All right, gentlemen.
Yeah. Yeah. Hey, thanks for having me on. I really appreciate it.
Hey, Alex, let's cover our ass real quick.
Oh, great idea, Drew. All right, guys. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent.
Thanks for tuning into this week's episode. Before you go, please rate and review the pod on the listening platform of your choice. You can also visit us on our website at www.mopsinmos.com. That's mops, the letter N, mos.com. You can check out the library of podcast episodes, our latest blog entries, any helpful resources, and also sign up for our newsletter.
Drew nailed it. Just to underline a couple of things, the podcast entries have in-depth show notes on the website. So if you missed anything or you want to read any of the research we talk about, it is all there. You can at the bottom of the website, sign up with your email and receive future updates from us. The blog posts go a little bit more in depth in kind of written form on a couple of topics we get questions about all the time. But most importantly, I just want to ask all you guys, our best way the word gets out is absolutely word of mouth. So tell your friends, tell the people you work with, anybody you think would find it useful. Thanks for spreading the word.
If you have any questions or comments, feel free to shoot us an email at either Drew or Alex at mopsandmos.com.
Or there's a contact form on the website.